As we all know, COVID has disrupted our lives over the last 18 to 24 months and continues to do so. And that's because it's associated with significant morbidity and mortality. And to understand how COVID infects our cells and causes organ damage, we have to have a basic appreciation of its pathophysiology. And that is that the virus has a spike binding protein, and this attaches to ACE2 receptors on epithelial cells. Following this process, a portion of the binding protein then gets cleaved by serine proteases, which subsequently switches on the virus, allowing it to internalize the cell, then replicate and set off an inflammatory cascade. So essential for the virus to act is the presence of ACE2 receptors. And you might envisage that the highest prevalence of ACE2 receptors would be in the oropharynx or the respiratory tract, but interestingly, the highest prevalence is actually within the gastrointestinal tract, which suggests that the virus can directly infect our gut. And this diagram nicely demonstrates the interplay between the virus and the GI tract. And what I'd like to draw your attention to is two main things. The first is label A, which is up here, and this shows how the virus attaches onto ACE2 receptors on the gut epithelial cells and then makes its way in and sets off the inflammatory cascade. But what's really interesting is also label C down here, and that shows that the virus can actually infect the enteric nerves, and that's because these harbor ACE2 receptors. So this subsequently leads to an infection of the enteric nervous system, which then leads to an infection of the central nervous system. So what this diagram demonstrates is a gut-brain infection. Moreover, another way in which the virus can cause its effects is through the process of dysbiosis. So on the left here, we have an individual who's healthy and their gut microbiome is healthy. But on the right, we have somebody with COVID-19 who has gut dysbiosis, as evidenced by an enrichment of opportunistic pathogens, which subsequently release metabolites, leading to inflammation and infection. So with that, the virus can cause GI symptoms. And the ones that we're probably most familiar with is altered sense of smell and altered taste, but others include symptoms that emanate from the upper gastrointestinal tract, such as epigastric pain and vomiting, and those that also emanate from the lower GI tract, such as diarrhea and abdominal pain. It can also cause deranged liver enzymes, and that's because the virus can travel via the portal vein and infect hepatocytes, as these also harbor the ACE2 receptor. So this was one of the first case series which looked at the symptoms that patients experience with COVID-19. And of course, at the top of the list, you'll have fevers and you'll have the respiratory complaints, but lower down, there's an appreciable subset of individuals that have GI symptoms. So for example, around 10% will have diarrhea and nausea, and around 2% in this case series had abdominal pain. What was another interesting observation is that around 1 in 10 people had GI symptoms before they developed the respiratory symptoms. So since that initial case series, there's been plenty of case series in the literature, and this has recently been pulled together in a systematic review and meta-analysis of almost 80,000 people with COVID-19. And the most frequent GI manifestations were diarrhea, which affects around 15%, nausea around 10%, and abdominal pain and deranged liver biochemistry around 5% each. It's also worth mentioning that individuals with COVID-19 may be shedding the virus within the feces in around 40% of cases, particularly those that during the illness are experiencing diarrhea. And what's also interesting is that the fecal RNA may remain positive even after the respiratory PCR has become negative, and it suggests about a 1-week lag phase. I'd now like to move on to long COVID, and this is something that came to our attention about a year ago, where a professor of infectious diseases wrote in about his ordeal with COVID-19 and described it as a roller coaster of ill health. Subsequently, people on Twitter were able to relate to this and coined the term long COVID, which has since stuck. And NICE defines this as symptoms that persist beyond 4 weeks from the initial infection. With regards to the symptoms of long COVID, they are vast, over 50, and around 80% of individuals will have at least one of those symptoms. And highlighted in the figure are the different symptoms that people may experience, and the ones with the bigger bubbles are the most frequent symptoms. So, for example, fatigue, headaches, attention disorders, hair loss. But what's relevant to this talk is that around 12% of individuals with long COVID will say that they've now got GI disturbances, which is a new thing for them. And just to emphasize this point further, this was a case series where individuals hospitalized with COVID were then followed up 3 months later, and around 15% were reporting GI symptoms. For example, abdominal pain, altered bowel habit, and nausea and vomiting. And then just to take that a step further, this is a case control study that's been published, which it took individuals with COVID, which were your cases, and those without COVID, the controls, and then followed them up 5 months later. And what they noted was that those with COVID were more likely to have loose stools, chronic fatigue, and somatization. So the question is, why have these individuals who've had COVID now developed these GI disturbances? It's unlikely that they've got an organic disease, like, for example, inflammatory disease or celiac or cancer, but it's more likely that they've developed some kind of functional gut disorder, which here they've termed post-COVID functional gut disorders, which kind of makes sense because, as I showed earlier, this is an infection of the brain-gut axis, and maybe that's then been left irritable and hypersensitive. And this is very similar to something that we all should be quite familiar with, which is a concept of post-infectious IBS. And that is when an individual has a bout of gastroenteritis, 1 in 10 individuals will then be left with lingering symptoms that persist thereafter, in particular those that may have had a bad bacterial infection with Salmonella or Shigella, needed hospitalization, needed antibiotics, or those with underlying mood disturbances. And it's been proposed that maybe post-COVID functional gut disorders is very similar. How we manage these individuals is not yet clearly known, but because it's an infection and dysbiosis may be involved, some have hypothesized that maybe we can use probiotics or dietary alterations, but that remains to be proven. And of course, before COVID kicked in, we had a lot of individuals under our care that had functional gut disorders. So what's happened to them during the pandemic? Well, they've generally got worse. So they've started experiencing more gastrointestinal symptoms, more medication use, and more healthcare utilization. And a lot of that stems from the anxieties and deteriorating mental health that a lot of individuals, including a lot of general society, has experienced during the pandemic. And for those of you that are interested in celiac disease and inflammatory bowel disease, it appears that these individuals do not appear to be at a high risk of COVID compared with the general population. So I hope I've shown that GI symptoms are common in patients with COVID and may persist after the illness, which is long COVID. Looking at the results, a ballpark figure for me is around 10 to 15% experience GI symptoms during and after COVID. And the long-term sequelae of post-COVID functional gut disorders is not clearly known at this moment in time. Thank you so much for listening.
We have time for a couple of quick questions, if anybody has any questions. Can I ask you, Imran, like you mentioned, there are some patients who the risk of post-COVID is not very high, but which are the underlying GI conditions which do increase the risks of long COVID, post-COVID symptoms more?
So I think during the pandemic, there was a lot of concern that individuals with IBD may be at increased risk because they're on immunosuppressants. But that obviously, from the data I've been able to obtain, that doesn't appear to be the case. The ones that may be at risk of developing long COVID, I feel may be similar to the individuals that may be at risk of developing post-infectious IBS. So those have had a really bad infection, may have needed hospitalization, may have underlying mood disturbances, somatization before even COVID kicked in. These may be the individuals, but the data out there is still coming through.
Thank you. There's one question which has been posed. Any data on GI symptoms after vaccination?
I'll put my hand up. I haven't got a clue. I don't know.
Thank you. Anybody for any more questions? Thank you.
move on to the next.
Thank you.